Good afternoon, everyone. Well, my talk today will be about pulmonary vein isolation in dextrocrdia and situs inversus totalis. Dextrocrdia is a congenital anomaly in which the heart assumes an abnormally right-sided location within the chest cavity or the thoracic cavity. And it's primarily due to abnormal lateralization of the left-right axis of the heart during early development. In normal situations, the heart assumes a left-sided position in the chest cavity with the apex directed to the left side, and this position is known as levocardia. But when the base apical axis of the heart shifts to the right side or flips to the right side and the heart becomes right-sided in the chest wall or inside the thoracic cavity, it's called this condition is called dextrocardia. And there are two important entities in it, the mirror image dextrocardia and the dextroversion. In mirror image dextrocardia, the orientation of the chambers, of the cardiac chambers, is mirror image to the normal, where the right atrium and the right ventricle, they become the left-sided chambers, while the left atrium and left ventricle become the right-sided chamber. While in dextroversion, the orientation of the chambers is the same as in levocardia, but the heart is shifted to the right and the apex is shifted to the right. There is another entity or another definition that is important that we have to know in the event of any congenital anomaly or congenital heart disease, including dextrocardia, is the situs. The situs is defined as the relationship between the position of the atria and the abdominal viscera, as well as the tracheobronchial tree. And you have a normal situs, which is situs solitus, where the viscero-atrial relationship is normal. Your right atrium is in the right is on the right side of the vertebral column together with the liver, and the stomach is in the left side. While the situs inversus, where the viscero-atrial relation becomes mirror image or reversed, that the right atrium becomes left-sided together with the liver, and you have the stomach on the right side of the vertebral column. So we have situs solitus, this is normal situs, and the situs inversus, which is the abnormal or the reversed relationship together. Also, the ascending aorta, the aortic arch together with the descending aorta, their position goes with the situs. In normal situs, the descending aorta and the arch becomes left-sided, while in situs inversus it becomes right-sided, has a right-sided position. In dextrocardia, the most common association with dextrocardia is situs inversus. It's very rare to see an isolated dextrocardia. And dextrocardia per se is a very rare congenital anomaly, and its incidence is about 1 in 8,000 or 1 in 25,000. So we can say that you cannot see it frequently in your EP lab. It's not an everyday procedure you can do to find the situs or dextrocardia or situs inversus to do a procedure in it. As we all know that recently pulmonary vein isolation has become a cornerstone procedure for treatment of or for ablation of patients with recurrent symptomatic atrial fibrillation. And it's a complex procedure, and in case of abnormal anatomy, this makes the pulmonary vein isolation, which is a primary complex procedure, makes it more challenging and may increase the risk of complications, especially during transseptal puncture. So beforehand, or before doing a case or a pulmonary vein isolation in a patient with dextrocardia, you have to do proper planning. You have to think about the anatomy to understand to understand the underlying anatomy, especially its orientation under fluoroscopy or the chamber orientation under fluoroscopy. Also, you can use the help of other imaging modality prior to the procedure or during the procedure to help you understand the anatomy or to know the chamber orientation. Also, you have to recognize the difference in conventional fluoroscopic views. Since the heart is flipped to the right side, so your conventional fluoroscopic views are also reversed. So your REO becomes your LEO, and your LEO becomes your REO, and you have to know this before the procedure. In literature, there is a handful of reports about PVI isolation in dextrocrdia and situs inversus totalis, and this is very expected, and all of them are case reports. And this is very expected because this is a very rare congenital anomaly. The very first report about pulmonary vein isolation in dextrocrdia and situs inversus totalis was back in the year 2008, and PVI isolation was done using RF energy, and they did the whole procedure under fluoroscopic guidance. They didn't use any other imaging modalities during this procedure, and they didn't do a transseptal puncture. Actually, they had a PFO, so they put their transseptal sheath through this PFO, and they used left atrial and pulmonary vein angiograms to understand the anatomy and to understand the geometry of the left atrium together with the pulmonary veins. And it's very interesting. Here, this is the coronary sinus introduced through a femoral vein puncture, and we can recognize that the coronary sinus is on the right side of the vertebral column, it's not on the left side, because the mitral annulus is actually right-sided, it's not a left-sided structure anymore. And during pulmonary vein angiography and left atrial angiography, you can see that the left atrial appendage is related to the right-sided pulmonary veins, not the left-sided pulmonary veins. And they can record a far-field atrial electrogram in the right-sided pulmonary veins coming from the left atrial appendage. In the next year, the first report about pulmonary vein isolation in a patient with dextrocrdia and dextrocrdia and situs inversus totalis was published in 2009. And the pulmonary vein isolation was carried out using a magnetic navigation system in addition to 3D mapping system, which is the CARTOS system. They did the transseptal punctures it was also done under fluoroscopic guidance, but they used inverted fluoroscopic images. So they flipped the images of the heart to the left side to resemble the normally positioned heart. And they used 3D electroanatomical mapping system to create a 3D map of the left atrium and the pulmonary veins, as we can see here. And also they used a pre-acquired 3D reconstructed CT images of the left atrium as well as the pulmonary veins to help them understand the anatomy and to navigate for easy navigation of the catheters inside the left atrium, and makes the mapping and ablation and creation of the circumferential pulmonary vein isolation to make it more easier. And it was a very successful procedure, and it didn't take time. There was no complications, and there was no recurrence after 12 months of follow-up. In the year 2016, that's the year where the first report about cryoablation, pulmonary vein isolation using cryoablation, that was in 2016. And here in this procedure, they used intracardiac echo to guide them through their transseptal punctures, a single transseptal puncture. And they used a 3D reconstructed image or model of the right atrium and left atrium to make the procedure more easier. As we can see here, this is an aerial view. This is our CT reconstructed 3D reconstructed images of the right atrium and the left atrium. In aerial view, we can see that the right atrium is on the left side, and on its right side, hand side, is the left atrium. The left atrial appendage is related to the right-sided pulmonary vein, and the left-sided pulmonary vein is actually related to the SVC. And they done mapping and ablation using the Navic system for guidance after integration of the 3D CT model of the left atrium and pulmonary veins. All pulmonary veins were successfully isolated with no complications. Then we come to our case. In our series of pulmonary vein isolation, we had only one case of ablation in dextrocrdia and situs inversus totalis, and it was the first time for me to do a transseptal puncture in dextrocardiac patient. I did previously an avinular entrant ablation in dextrocardia, but I've never done a transseptal puncture in dextrocardia and situs inversus totalis. Our patient is a 33-year-old male patient. He had a 3-year history of recurrent paroxysmal atrial fibrillation that was not responding to antiarrhythmic drugs, and he needed repeated cardiovergence, so pulmonary vein isolation was planned for this patient. His resting ECG, this is the ECG seen in the upper right-hand side. This is his ECG with a normally hooked ECG leads. We can see it shows a picture suggestive of dextrocrdia. You have a right axis deviation. You have a completely negative waves in lead 1 and completely positive waves in AVR with very poor R wave progression or failure of R wave progression in the chest leads. That's suggestive of dextrocrdia, and when we reversed the ECG leads, it became a completely normal ECG. The echo showed a picture of dextrocrdia. There was no other congenital heart disease, thank God, because it will make our life more miserable, and the transesophageal echo was normal. Before the procedure, since we have very limited resources, so we couldn't do a procedural CT CT for this patient to see reconstruction of the left atrium of the pulmonary veins to help us understand the anatomy. So we did a review of literature, and we understand the anatomy. We have a mirror image dextrocrdia in our hands. Also, we tried to understand the chamber orientation under fluoroscopy. فيديو بس هشغله دلوقتي ثانية واحدة التعليم. شغله ازاي؟ هي دوس عليه ازاي؟ لا الفيديو مش شغال. بس كان شغال برضه. اوكي انا شغال، انا جربت. انا مش شغال دلوقتي. نفس المشكلة اللي حصلت من دول. عندنا فيديوهات كتير. ادوس عليه بالبوينت. Okay. We started our procedure by introducing our diagnostic catheter. This is the decapolar catheter that is going to land in the coronary sinus, and we can see here clearly that we have a left-sided IVC. Okay, because we have a situs inversus totalis. Then this is the decapolar catheter going into the coronary sinus, which is now on the right side of the vertebral column. This is an REO view, and the tip, you can see the tip of the coronary sinus is pointing towards the right-sided pulmonary veins, not the left-sided as we see in normal situations. And then after placing our diagnostic EP catheter, the decapolar catheter inside the coronary sinus, and his catheter, the quadripolar catheter in the his position, we started doing our transseptal puncture. First, our transseptal puncture, and we tried to do it under the guidance of transesophageal echo, but we failed to do it. We couldn't get our views right. I don't know why. So we resorted to do it under fluoroscopic guidance. And we injected dye while we were going down with the transseptal puncture needle. You can see that the transseptal puncture needle was directed to the right side, not the left side. So this is the reverse of the normal. And we injected dye, so it made us more comfortable. We orient our anatomy very well, and we could see the septum, the position where we are going to puncture in the septum, and we checked our position both in REO and LO views. And here we can see we punctured successfully the septum and went into the left side. Later on, this is our sheath, first transseptal sheath inside the left atrium, and we're going inside with the circular catheter inside the left atrium and positioned it into the right superior pulmonary vein. And this is the recording coming out from this circular catheter, showing up sharp potentials, which are the pulmonary vein potentials. Preceded, as if we look carefully, we can see it's preceded. PVPs are preceded by a far-field atrial electrogram. This is the far-field atrial coming from the left atrial appendage that is now related to the right-sided pulmonary vein. Sorry. And this is our second transseptal puncture. We did it the same way while injecting dye to delineate the interatrial septum, and then we checked our position in both REO views, REO and LEO views. And this is here is injection into the left atrium. Okay. And and now both catheters are in. The circular catheter, we can see it here in the left superior pulmonary vein, and the ablation catheter is crossing the mitral annulus, so we have 2 transeptal punctures in. We started doing our 3D anatomical and voltage map. I'm sorry, I don't have an image of the voltage map. We started creating our voltage map of the left atrium and an anatomical map using the NAVIX system version 4. And before we did the procedure, we flipped the patches, the right and left patches. So now we have a dextrocrdia on the fluoroscopy and an inverted images on the NAVIX system. As clearly seen that the coronary sinus now on the left side now, not on the right side, but there's an important point to note that the left-sided pulmonary vein here on the NAVIX or image are actually the right-sided pulmonary veins. They are not the left side, and in front of them is a very tiny left atrial appendage. It was very difficult to manipulate our catheter inside the left atrial appendage and to have, so we went inside a bit, and we finished our map, our anatomical map successfully, and started creating our circumferential ablation lesions around the both right and left pulmonary veins, and we ended up by complete isolation of the pulmonary veins with complete disappearance of the PVPs on both sides. This is entrance block, and I think we ensured also using exit block. The procedure was successfully done with no complications and no recurrence on 6 months follow-up. Finally, dextrocrdia is a very rare congenital anomaly which commonly occurs in association with situs inversus totalis. Abnormal anatomy poses a challenge in the face of any cardiac interventionist, especially for complex ones like pulmonary vein isolation, for the fear of increasing the risk of complications or failures. So it's crucial to understand the underlying anatomy prior to the procedure and use the aid of different imaging modalities to decrease the risk and increase the success rates. Data on PVI isolation in dextrocrdia and situs inversus totalis are limited because it's a real anomaly. But all the reports showed safety and efficacy of the procedure. Thank you.